Assalamu alaikum, everyone. Good afternoon to the 19th Shaukat Khanum Symposium that is taking place right now. I welcome you to the free paper session 3. I don't want to hold everyone. We have a busy session. We have about 9 presenters that are going to be presenting their research today. I would recommend and suggest to all the speakers that please use 8 minutes for your presentation, and we'll take 2 minutes to take question and answers from everyone who's attending. Before we start, there are about 9 presenters. If anyone has any questions for us or presenters, I would request them to use question and answer session. That will be really helpful for us. Please don't use the chat feature. So first presenter is Samin Mohtasham. And this presenter is going to be presenting on locally advanced oral tongue cancer. Is organ preservation a safe option in resource-limited high-volume setting? Over to you.
Thank you, sir. Good morning, everyone. My name is Samin Mohtasham. I am a resident in surgical oncology at Shaukat Khanum Hospital. And my presentation is locally advanced oral cancers. Is organ preservation a safe option in research-limited high-volume setting? So a disclosure, I have no financial interest or arrangement or affiliation that would constitute conflict of interest. Little introduction. Head and neck cancers account for more than 550,000 cases which are diagnosed annually with a male to female ratio of 4:1. Conventionally, advanced oral cancers have been treated with surgery, which is followed by adjuvant radiotherapy with or without chemotherapy, depending on the final histopathology. What this does is that it leads to excessive loss of tissue. Following surgery will lead to a loss of function of oral cancer, which is mainly speech and swallowing. Oral tongue is the most common intraoral subsite of head and neck cancers, which has a worse prognosis, with a local recurrence of 30%, distal metastasis of 25%, and a very dismal 5-year survival of 50%. Induction chemotherapy has been used in many studies with an objective to increase overall and disease-free survival. Even though multiple trials have not depicted expected results in terms of overall survival, there has been an increased interest in using the induction arm as a modality of treatment in recent times. So the aim of our study was to report the survival outcome intermediate to advanced oral tongue cancer patients using induction chemotherapy, followed by surgery and postoperative adjuvant treatment with effective tissue preservation. It was a retrospective study. Record of 100 patients who were treated at Shaukat Khanum was analyzed between 2007 and 2016. The inclusion criteria was previously untreated cancers which were biopsy-proven oral tongue squamous cell carcinomas with a clinically intermediate or advanced stage, which is stage 2 to 4. And the exclusion criteria were incomplete medical records, patients who were lost to follow-up, and patients that weren't able to complete treatment due to chemotherapy-related toxicity. Ultimately, out of those 100 patients, 81 were enrolled in the study. A little bit about our treatment protocol. The diagnostic workup included a complete history and examination, dental radiographs, contrast-enhanced MRI, chest X-ray, and baseline blood tests. Eligible candidates received 2 cycles of induction chemotherapy, which was followed by surgery and adjuvant treatment. The response to chemotherapy was measured by an MRI 2 weeks post induction chemotherapy, followed by surgery within 4 to 6 weeks after completion of the last cycle. Partial glossectomy and neck dissection was performed as the surgical treatment, and flap reconstruction was reserved for those with loss of more than 30% of tongue musculature. When we measured response to chemotherapy on the final histopathology, there were 3 categories. One was no residual disease. There were complete responders. If there was microscopic disease on histopathology, those were classified as major responders. And if there was gross disease on histopathology, they were classified as partial responders. And nodal dissection was characterized as responders for those who had no nodal disease and non-responders for those who had node positive disease in final histopathology. SPSS software was used, and mean plus minus standard deviation was used for continuous variables. Frequencies and percentages were used for categorical variables, and Kaplan-Meier method was used to estimate survival. And statistical significance was defined as p equals to or less than 0.05. We briefly discussed the results. The mean age was 49 years with 45 male patients and 36 female patients, and risk factors were present in 60% of these patients. If we come to the histopathology, the most common squamous cell carcinoma was moderately differentiated. Most of these patients underwent unilateral neck dissection with 79%. Currently, if we look at their status, 72% of these patients are alive. And those who have died, 96% died of because of their primary disease. 4%, which was one patient, he died of cardiac disease. If we discuss the adverse histopathology features, perineural invasion was seen in 16% of the patients, and lymphovascular invasion and extranodal extension was seen in 2.5% of patients each. 31% of patients had a recurrence, out of which 40% was local and 12% was distal. If we compare the pre and post induction characteristics of the tumor, the pre induction tumor size was 3.96 centimeters and the post induction was 1.77. The most common T stage of patients pre chemo was 38%, and post chemo it reduced to T2, which was 30%, sorry, T1, which was 31%. Most of these patients were N not even before chemo, which was 57%, but that increased to 65% post chemo. Complete nodal response was seen in 14% of the patients. If we come to the overall stage, before starting chemotherapy, the most common stage was T3, was stage 3, which was 38%, which downsized to stage 1 in 33% after induction chemotherapy on final histopathology. The mean difference of tumor size after induction chemo was 1.63%, which had a p-value of 0.01, which is significant. If we see response to chemotherapy, complete responders was 13%. Most of our patients had microscopic residual disease, which was 75%, and only 21% of the patients received reconstruction using local or regional flaps. Our median follow-up was 24 months with an overall 3 and 5 year survival of 77 and 58% respectively. And disease-free survival 3 and 5 years was 58 and 62%. In conclusion, induction chemotherapy has shown promising results in locally advanced low nodal volume intermediate to advanced stage oral tongue cancers with functional tongue preservation. The reduction in tumor volume is more significant at primary site, but the response to high volume nodal disease has been dismal. Our study has recommended that selective group of patients who can benefit from induction arm for functional survival outcome in less privileged high volume centers. Our limitations was there was no prospective comparative study using surgery followed by radiation in the same subset of patients. Biomarkers are needed to identify the subset of patients that respond to chemotherapy, and this approach needs further validation in clinical trials. Thank you.
Thank you very much, Dr. Mohtasham, for this presentation. I'd like to ask a question just to begin things. So in this study, you did identify one of the limitations was that there was no control arm, but are you planning on implementing a randomized control trial of patients who would benefit from induction chemotherapy compared to those that will get like a placebo or no therapy at all?
There's no trial under consideration at this moment, but there is something that we can consider in the future.
Okay. If anyone else has any questions, which I don't see right now, we'll move on to the next presentation. Thank you so much. Our next presenter is also from Shaukat Khanum Memorial Cancer Hospital from the Lahore site, Dr. Taqir Zahid. He's going to be presenting on role of fine needle aspiration cytology in the diagnosis of parotid gland tumors, analysis of 193 cases. I think that they are preparing Dr. Taqir right now for the presentation. It should be up soon. Again, if anyone has any questions, please feel free to ask them through question and answer window, or you can use chat feature as well. I see Dr. Taqir is ready. So I'm going to ask our host to switch our screens, and over to you, Dr. Taqir.
So my name is Dr. Mohammad Taqir Zahid. Good afternoon, everyone. I'm currently working as a resident general surgery at Shaukat Khanum Hospital. And I've talked about the study, the role of fine needle aspiration cytology in the diagnosis of parotid gland tumors. This study was initially performed at Khan University Hospital, and it's a collaborated study between Shaukat Khanum and AKUH. So first of all, talking about the introduction, we know that salivary gland tumors are quite rare, and approximately 3 to 6% of head and neck tumors belong to salivary gland, and they constitute about 0.6% of all the tumors of human body. Usually salivary gland masses involve 80%. In 80% of the cases, it belongs to the salivary glands, and almost 80% of them are benign on histopathology. So initially, WHO proposed classification of salivary gland tumors in 2005, which is quite widely accepted. It has 4 subcategories: the benign epithelial tumors, malignant epithelial tumors, soft tissue tumors, and hematolymphoid tumors. There is large histological variety of salivary gland tumors, benign or malignant. It's a quite diverse topic. FNAC is usually used as a diagnostic modality for parotid gland tumors, and it was initially introduced in 1920, and then it came into Europe and then the United States afterwards. It's a cytologically diagnostic method based on morphology of individual cells or group of the cells, and it also looks at the microparticles of the tissue to make the diagnosis. Traditional open biopsy is no longer justified because there is risk of tumor spillage and there is a high risk of damage to the facial nerve. So usually we perform FNAC. It is an easy procedure, minimal incidence of complication, less invasive, less chances of tumor spillage. So the rationale of the study was to evaluate the usefulness and the accuracy of FNA cytology in the diagnosis of parotid gland tumors. And its objective was to determine the sensitivity, specificity, positive predictive value, negative predictive value, and the diagnostic accuracy of FNA in the parotid gland tumors. So the design of the study was cross-sectional study. It was performed at AKUH, the ENT department, in collaboration at Shaukat Khanum, and the duration was from 2000 to 2015. Exemption letter was issued by AKUH and our hospital as well, and the technique sampling was non-probability consecutive. So the inclusion criteria was all the patients who had FNA of the parotid lump and the parotidectomy were included, and both of the procedures were performed at the AKU. Suppose if a patient has had the FNA performed at another hospital, that patient was excluded from this study. Exclusion criteria also included incomplete data and missing records. And if there's any previous history of treatment of parotid tumors anywhere at Shaukat Khanum, AKU, or anywhere else. So retrospectively, we analyzed 290 files, excluded 97 of them based on these criteria, and included 193 patients. So it was analyzed using SPSS. Then we used gender as a frequency in percentages in genders, symptoms, FNA, and the mean was calculated for age and duration of the symptoms. So while analyzing the data, we defined true negative as if there's absence of malignancy, which is diagnosed correctly. True positive meant presence of malignancy, which is diagnosed correctly. False negatives meant cytology specimen, which failed to diagnose a malignancy. And true positive meant like cytology specimen incorrectly diagnosed malignancy. So in our results, we had total 193 patients, and 83 of them were females. That is 43% of our total sample size. 110 were male, and which makes it 57%. When we talk about the age, like 48.2% was the mean age for males with a standard deviation of 16.1, and 43.76 was the average age for females with a standard deviation of 14.7. The mean duration of the symptoms was 41.3 months, and the patients, the most common symptom was swelling in the preauricular region, which makes it 100%. Almost every patient had this symptom. Almost 15% of the patients had pain, and 3.1% of the patients had weakness in the region of facial nerve. So when we performed the FNA, 75% of the patients had benign lesion, and 20.7% had malignant lesion, and it was inconclusive in almost 4.1% of the patients, which makes it almost 8 patients. So here's a 2x2 table. The true positives, which were like diagnosed as a malignant, there were 40 patients, and the false positives, there were 3 patients. When we talk about the benign, the false negatives were 5, and true negatives were 145. Talking about the sensitivity, so basically the sensitivity of this technique was 88.9% using this 2x2 table, and the specificity was 97.9%. So when we summarize the results, the sensitivity was 88.9%, specificity 97.9%, positive predictive value was noted in 93%, negative predictive value was noted in 97% patients almost, and diagnostic accuracy was almost 96%. When we compare our data to the rest of the world, we have different studies from different parts of the world. If we compare it, like between Italy, India, and Pakistan, like same hospital, Al Khan University Hospital, the study was performed in 2010, and then Sweden, we get this table. and our data was almost compatible with all of the previously published literature. So conclusion of the study is the results are comparable with the previously published literature, and it's a valuable tool for preoperative counseling of the nature and the prognosis of the disease, and to counsel the patient regarding the extent of the surgery, whether the patient needs neck dissection or whether the patient needs clearance radical periodontectomy or not. So the recommendations are FN is a useful diagnostic modality, and it can be used as a preoperative diagnostic tool. It helps us to differentiate between inflammatory and neoplastic conditions, and preoperative counseling of the nature and prognosis becomes easy to counsel the patient when you know the nature of the lesion. This is it. Thank you so much.
If anyone has any questions, please feel free to ask them. I, meanwhile, will go ahead and ask Dr. Takir. So you
Sure.
did mention that this study has a sensitivity, pretty good, excellent sensitivity and specificity, by the way. But when I was seeing the data compared to other countries, why do you think our number, or there is a variation? Is this technique sensitive? That's the reason, or is it because of the pathological tests or the services that are available in different countries that there is so variation between these rates?
So usually perform FNA like by two techniques. The one is like without the ultrasound, and the second one is with the use of ultrasound probe. So as we are progressing towards ultrasound, so it gets a better yield. You know where to hit the target, and this technique helps us to get a better result.
Okay. Thank you so much. I don't see anyone else asking any questions. We'll go ahead and we move on to the next speaker. Thank you once again, Dr. Takir.
Welcome, sir.
So next person who's coming in is also again from Shaukat Khanum Hospital. We have Dr. Masood or Rahman. He's going to be presenting on clinical pathological characteristics and survivor analyses of primary mucosal malignant melanoma. While Dr. Masood or Rahman sets up, I would once again let everyone know that we have total 9 presentations today, and we'll be going by one. 8 minutes are going to be used for the presentation, whereas 2 minutes in the end are going to be kept for questions and answers. I see Dr. Masood's screen has been set up, so I'm going to ask him to take over, and now you're going to hear from him now.
Good afternoon, everyone. My name is Dr. Masood. I am a fellow of surgical oncology in Shaukat Khanum Memorial Hospital. Today, my topic of discussion is clinico-pathological characteristics and survival analysis of primary mucosal malignant melanoma, an experience from a dedicated cancer center of the Pakistan. So starting from the introduction, malignant melanoma are actually derived from the melanin producing cells, melanocytes, which are derivatives of neuroectodermal cells. Malignant melanoma frequently arises from cutaneous surfaces, although they can rarely originate from mucosal ocular membrane, mucosal membrane of the respiratory tract, gastrointestinal tract, genitourinary tract, leptomeningeal surface, and rarely from the internal organs. So the primary function of melanocytes are actually the pigment production in the cutaneous epithelium and protection of skin from ultraviolet sun rays. The antimicrobial and immunological functions of melanocytes have been studied, and their relation with the innate immunity has been established. Malignant melanoma of non-cutaneous origin are very rare, non-specific, aggressive cancer, and they show very poor prognosis. So the overall survival rate and incidence of the disease is very low, and most of the patients report at very late stages of the disease, with either with locally advanced and metastatic or with the metastatic disease, which actually curb the formulation of the specific treatment for the disease. Therefore, to overcome the current problem, it is important to make the diagnosis as early as possible, because prognosis gets worse with the time. Currently, local regional control of the disease is done with the surgical resection followed by adjuvant chemo and radiotherapy, which is effective, but it does not unfortunately it does not help with the better prognosis. So the detailed study of clinico-pathological characteristic, its epidemiological factor and site specific prognostic factor is prerequisite to control the disease progression as well as to prompt the diagnosis as well. So these factors are not well established in case of mucosal malignant melanoma. My study will provide the missing part of the puzzle because data as well as studies on the mucosal malignant melanoma from this region are very rare. Considering the diverse nature of this disease, it is important to know all the demographic details, clinical pathological characteristic, management of the disease, and survival outcome of better understanding and management of this type of malignancy. Now on the methodology, during 1st January 1995 to 31st December 2018, patient presented with the histopathological and radiological diagnosis of primary malignant melanoma at Shaukat Khanum Memorial Hospital and Research Center were selected. It is a retrospective study with the convenience sampling. A patient with history of cutaneous mucosal malignant melanoma or its metastatic disease at presentation were excluded. The ethical approval was sought from the IRB. Data was collected through the HIS system. Variables which are recorded were age, gender, pre-surgery histopathology, clinical staging, management of the disease, surgical finding, post-operative complication, and survival outcomes were recorded. As per local guideline of the hospital, extensive pre-operative workup was performed, including baseline labs, CT scan, MRI scan, PET scan were indicated. All the patient which were are discussed in the MDT. So MDT calculation was were performed on the SPSS 20. Data was described using median and median with minimum and maximum value of squarely distributed quantitative variables. For categorical variables, number of observation and percentages were reported. Kaplan-Meier method was utilized for the determination of survival and prognosis of the disease. The study is compiled with Shaukat Khanum Memorial Hospital in Research Center guidelines on research involving the human object. During the span of 2 decades, 269 patients were presented with the histological diagnosis of malignant melanoma. 163 patients has cutaneous malignant melanoma, 98 patient, which comprises about 36.4% patient had mucosal melanoma. 5 patient had ocular malignant melanoma. 3 had visceral malignant melanoma. Out of all the malignant melanoma, anal canal was the most prevalent site, followed by mucosal melanoma of the head and neck, and then female genital tract. Only 1 patient who also had malignant melanoma of the urethra. Um, uh, median age at the diagnosis of mucosal malignant melanoma was 53 years. 52 patients were from the Punjab, 25 patients were from the Khyber Pakhtunkhwa, 3 were from the Sindh, and 2 were from the outside of the Pakistan. Male were predominantly more affected than the females. Almost 50% of the patient with anorectal mucosal malignant melanoma presented with painless bleeding per rectum. The commonest presentation in the patient with melanoma of head and neck were epistaxis and the mass in the nasal cavity. In the cohort of the female patient with genital mucosal melanoma, per vaginal discharge and the mass in the vagina were the commonest system. Median duration of the symptoms was 8 months. Genital malignant melanoma had the most favorable survival outcomes of the 25 months, followed by the anorectal malignant melanoma, which has the survival of 22 months. The worst survival outcomes were noticed in the patient with the malignant melanoma of the head and neck region, which is about the 10 months. Median overall survival of the malignant mucosal melanoma was 19 months. There are few limitations of this study, such as retrospective nature, which does include and which does introduce an element of bias associated with such studies. Primary mucosal malignant melanoma is a rare disease of aggressive nature. The prognosis of the disease varies in the patient with different anatomical site. Despite of the adequate management, which include the surgery, chemotherapy, and radiotherapy, still the local recurrence is very high. These this study reports very poor overall prognosis. This study cannot be used as the guideline for the management of the disease. However, this is the first study from this region which can used as the reference point for the future studies.
Thank you very much for this presentation. Um, I don't see any questions from anyone, but Dr. Masood, can you elaborate what else can we do from these results when you say it's a reference point? In what reference or what regard do you mean that? Can this still be used as in way of treatment management, or you think that this cannot be used at all when it comes to managing and treating these conditions? Because I do understand that this is a very rare condition, so it doesn't matter whether it is a retrospective or not, because usually we can't do much in terms of, in your case, I think you took the data from 1995 to 2018, which is almost more than 20 years. So even in that case, we had just more than 200, just slightly around
Yeah.
200 cases, right?
Yeah.
So
Yeah.
what do you think in other things in terms of your results, how else can we use them for patients?
Uh, the most important is when we have the female presenting with the pervaginal discharge, or the male patient with the anorectal bleed. So by this study, at least we should consider the malignant melanoma in our mind as the differential diagnosis of that condition. So as this condition is very lethal in head and neck malignancy, so the patient presented with the epistaxis, so we have to keep in mind that malignant melanoma may be the cause of the epistaxis. So by this study, I'm yes, I agree that this study cannot change the perspective of the treatment of the patient, but at least this study can persuade the treating doctor to at least consider the malignant melanoma in his or her the differentials.
Great. Thank you so much.
Thank you.
Really appreciate you answering my questions. I am now going to ask Dr. Umar Said from Patel Hospital, Karachi, to present next. His topic of presentation is risk factors associated with disease recurrence in patients with advanced stage squamous cell oral cavity, I'm assuming, treated with surgery and post-op radiation therapy. I can see Dr. Umar Said logging in. Can you please share your presentation with us, Dr. Said? I think there is some connectivity delay going on. While they sort that out, I would remind everyone that if there are any questions for the presenters, you can either use the chat feature or question and answer feature to ask these questions. While they do set up Dr. Said, his topic will be on risk factors associated with disease recurrence in patients with advanced squamous cell carcinoma, treated with surgery and post-operative radiation therapy. He is joining us from outside the facility, so that's why I think it's taking so long for the connectivity to take place. Dr. Said, it practices from Patel Hospital, Karachi. Okay, so I see there's something, some connectivity issue going on. So meanwhile, they sort that out. I'm going to ask Dr. Shahid Ahmed Khan to step in. Dr. Shahid is from Shaukat Khanam Hospital. He's going to be presenting his paper on assessment of pain at induction with propofol mixed with 2% lignocaine by visual analog scale. Dr. Shahid, if you could unmute your mic and you are good to go.
Sir, Assalamu alaikum everybody and good afternoon. I'm Shahid Ahmad Khan. I'm from Anesthesia Department, Shaukat Khan. I'm currently working as a fellow in anesthesia. So the topic which I would be presenting would be the assessment of pain at induction with propofol mixed with 2% lignocaine by the VL analog scale. So let's come to the key points which we would be discussing in this talk. It would be introduction, objective, then material methods, statistical analysis, and finally the results. So Mr. Morton was the one who made it easy for us to give anesthesia to the patient, and the anesthesia was given to him by the Aidan Frost by 30th September 1846, and the agent used was diethyl ether. So then later on, the introduction of the propofol led to the modern anesthetic technique, and it came into account in 1973. So 234 million roughly patients received general anesthesia all over the world, and out of these, roughly 8,000 received anesthesia in our setup. But this data is from about 2 years back, so might be the number would be different. So currently the propofol is the induction agent of choice, which is currently internationally used. But it makes sometimes unpleasant for anesthesia practices. Why does it become unpleasant? Because it causes pain on induction, means when the propofol is given onto IV, it gonna cause some pain. So some initial studies like Mr. Briggs, he found out the incidence of pain was 39% when it was given onto the dorsum hand, and 3% when it was given in antecubital fossa. And later on, Beher and likewise Mr. McCulloch, these all find out that these different techniques can be used for the introduction of reduction of pain. And later on, it was also find out that dexmedetomidine, it is also used, and sometimes, for example, in a Cochrane, they use that lignocaine. Either it can be given to determine whether pain reduction occurs and how much reduction of pain occurs. So it reduced to 38.1 to 11.8 after mixing lignocaine. So in our study, which we are going I would be presenting is the frequency of severity of pain at induction with propofol mixed with 2% lignocaine. So pain was assessed by using VL analog scale, and the lignocaine which was used, it was 2%. In initial studies, it was somewhat 1% and somewhat it was 4%, but here it was 2%, which is normally available in the ampule form. So our hypothesis was that it is going to reduce significantly the incidence of pain. So it was basically a descriptive case series. It was done in Shaukat Khanum from Jan 2018 to July 2018. It was a 6-month tenure with the 239 patients enrolled with the non-probability consecutive sampling technique. And the formula which was used, it was n is equal to z square into p1 minus p over d2 square. So 2 mils of lignocaine was used, mixed in 20 mils of propofol. Pain was assessed by looking at the face. So it was facial pain scale, which was mainly monitored. And the data which was derived, it was then put up into the SPSS-20 program, and mean and standard deviations like continuous variables like age were presented, categorical variables like severity of pain, types of surgery, in which we took the data from the urological, breast, and GI surgeries, and data was stratified for age, gender, BMI, ASI, ASA 1 and 2, and then post-stratification chi-square test was used, and it was used for taking p-value of less than 0.05. So in the result section, it was stratified according to the sex. In the male, they were 115 patient, female 124. In the surgeries, urological surgeries was 109, GI surgeries was 67, breast was 63. And in the sex variables, in the ASA variable, one patient was only ASA1 and the remainder 238 patients were the ASA2, because here the most of the patients are cancer patients. So in pain scores, there was no pain in 178 patients. So no pain was asked or counted when the pain score was from ranging 1 to 3. And when the pain score was 4 to 6, it was mild, which was in 47. And in severe, it was 14, which was 5.9%. So for BMI, it was normal, obesity, and morbid obese. and these variables are also given. Then they were stratified according to the age, up to the 40 73%, 73 patient, and above 40 166 patient. And then they were divided according to the male and female sex. Obviously no pain, mild, severe pain. And here the p-value was significant statistically, 0.01. So the severe pain reduced, it ranged up to 5.9%, but in the apparent study, which was Cochrane, it was 11%. So in the surgeries, urological, gastrointestinal, and then the breast surgeries, and then the ASA variables, then BMI, age in years. So there was no pain in 178 of these patients of 239. Pain was mild in 47 patients. Pain was severe in 14 patients, which was 5.9%. And the male had no pain, which were 96. Likewise, they were in moderate pain were 15 and 4 were in severe pain. And amongst the female, there was 82 with the no pain, 32 females with mild, and 10 female had severe pain. So when it was statistically seen that as per severity of the pain changed, it changed from mild, moderate, and severe. Severe had less, which was 5.9%. But as per categorically variables of the BMI, age, or any other variables, there was no statistically significance was seen. It means that pain would be present whether the patient is young or whether he is old. Propofol is going to cause same pain. But after mixing of lignocaine, it led to the reduction of the pain, whether it was the type of surgery, it was not influencing, whether it was the anything else, it was had no significant value, but the value which paid an importance was the mixing of the lignocaine. So it was concluded that from this study that lignocaine 2% can be mixed with propofol for reduction of pain of propofol, which propofol causes on induction of anesthesia. And this was the performer which was used, and the person who took the data, they were initially trained for this whole procedure, that how they would be calculating the pain and how it can be marked. Thanks. Any questions?
Thank you very much, Dr. Khan. There are quite a couple of questions. I think you did answer one of them briefly by at the end of the presentation, but I'll still ask you. So, in your presentation title says that the pain was made using visual analog scale, but in reality, it seems that you used a facial pain scale. Is that
Facial
correct?
stain, yes, sir, that was correct. Because
Okay.
the difficulty which we were counting, if we would have gone by visual analog scale, then after giving propofol, patient would have been sedated. It won't have been possible for the patient to mark onto the line at which level he's currently experiences the pain. So the sedative effect propofol might would have hindered our results. So that's why.
Okay. The other question that I actually have is that the pain assessment was done, you said, by a person who was trained. A single person did the assessment in all of the
No,
patients, or
no,
they were
single
two different
person
people?
was not. There were year 3 and 4 trainees. They were initially about 5%. They were trained that how to calculate the pain from the facial analog scale, and then they mark the pain scores.
Okay. And was there any efforts done in order to check what's the inter researcher reliability in terms of who assesses what? Because usually when we see these kind of studies, it's very interdependent on the person who's assessing them. For example, for me, someone's facial expression might be 4, whereas for someone else, they might be 2 or 1.
So they usually they had the performer in their hand while they were looking at the face of the patient. So it was the interpretation was compared with the performer.
Okay.
It was not something that performer was absent. Performer was always present there, and they were comparing it with the performer.
Okay. If no one else has any questions, I'd like to thank Dr. Khan. Up next, we
Thank you.
have Dr. Umar Saeed. I think they have sorted the electronic issue that was going on. Dr. Saeed comes from Patel Hospital, Karachi. He will be presenting on risk factors associated with disease recurrence in patients with advanced stage squamous cell carcinoma treated with surgery and post-op radiation therapy. Dr. Saeed, if you don't mind sharing your screen, I'm going to ask our host to switch the videos so that everyone can see you, and please unmute your mic so that we can hear you as well.
Assalamu alaikum. First of all, I would like to thank Shaukat Khanam Hospital for giving us the opportunity to present our literature. So, we all are aware of high incidence of oral cavity squamous cell carcinoma in our region, and mostly these patients present in advanced stage. So the highest incidence of disease in the world, local data is lacking, and we have to consult international literature. So this study will help us in determining the disease pattern of our patient, and thus we will no longer be dependent on international data. This is a study in which we try to identify the risk factor associated with disease recurrence in patients with advanced stage squamous cell carcinoma of the oral cavity treated with surgery and post-op radiotherapy. So I am Dr. Umar Said Harun, Resident Medical Officer of Department of ENT Patel Hospital, and I was supervised and assisted for this study by my head of department, Dr. Nabil Humayun, and other consultants and colleagues. All right, so squamous cell carcinoma is adverse with high chances of recurrence, especially in advanced stage. So, and among the different subsite oral cancer, we know the buccal mucosa is the most common site, and the most common causative factor is tobacco, and its consumption is quite common in Southeast Asia. Hence, we see the highest incidence worldwide in our region. As far as the local history of Karachi is concerned, the oral cavity squamous cell carcinoma is the commonest cancer in the male population, and in female, it is the third most common malignant tumor. All right, so as I have already mentioned, the reason being the use of tobacco, especially in the chewable form, I would like to show two interesting studies. The first one was conducted in 2003, which was multi-center study that showed 76% of the patients who were attending the hospital for any reason were addicted to tobacco. And a similar study, which was conducted after 10 years in 2014, showed the similar consumption in general population. Although we identified the risk factor in 2003, but we did nothing to alter our habits even in 10 years. All right, so on the other hand, these exposed patients have a limited access to modern healthcare facilities, which result in presentation of this patient in advanced stage with guarded prognosis and worse outcomes. All right, going towards the outcomes. So you all know internationally the outcome is generally predicted by TNM classification. However, the precise importance of prognosis is not reflected by this system. Recently in 2018, the addition of DOI in TNM has improved its prognostic value, but still there are factors which may impact the prognosis are lacking in TNM, like tumor volume and status of surgical margins. All right. Once the tumor is staged, among the different treatment options, the gold standard is surgery, followed by adjuvant radiotherapy or CCRT, as mentioned in the NCCN guidelines. However, even with radical sophisticated surgery and adjuvant treatment, which has significantly improved in the last few decades, the overall survival remains unchanged. Hence, the investigation tried to approach the disease by a non-orthodox approach like neoadjuvant, chemo, and definitive CCRT. All right, so there is abundant data recently that has shown surgery is still the hallmark treatment option. As you can see, the large study of nearly 7,000 patients, which has clearly shown better outcomes in surgical group. However, consistently, quaternary reports have shown that comparable outcome can be achieved by omitting surgical resection, as you can see in the recent slides. All right, talking about the surgical resection, although leads to tumor ablation, but resulted in major changes in life like decreased mouth opening and compromised facial appearance. Okay, so hence surgery, even if it curbs the disease, does it at the cost of major transformation in life. Therefore, it is imperative to identify and select patients who have maximum benefit of surgical resection. All right, so talking about the objectives. With this background, we designed this study and reviewed high volume single institute experience of treating advanced stage squamous cell carcinoma of oral cavity patients surgically and identified the factors which impact the final outcome in terms of recurrence, overall survival, and disease-free interval. All right, going toward the material and methods. So this is a retro respective observational study from January 2009 to December 2018, in which different factors were evaluated and their significance with the study endpoints were observed. So talking about the results, you can see we included 83 patients, and out of most of them were male. So all patients older than 18 years of age were included, but most of the patients you can see belong to the 31 to 50 years age group with a median of 6 years. All right, talking about the frequency, these are the different variables that were evaluated. And as we can see that most of the patients, that is 92% patients, had some sort of addiction. On univariate analysis, the closed surgical margin and vertical and burden of cervical lymph node metastasis was found to be significantly associated with lower disease-free survival. Hence, the higher chances of recurrence. However, on multivariate analysis, the surgical margin status has lost a significant, but still it is quite close to the significant p-value. But burden of cervical nodal disease is highly associated with poor outcomes. So talking about the recurrence in our study population, the recurrence rate, you can say either local, regional, or distant, was found to be 55%. All right. So looking at the survival curve with Kaplan-Meier curve with a median follow-up of 14 months, the overall survival was 42.2% and the 5-year disease-free survival was 45.8% with the median follow-up of 13 months. All right, so in an attempt to identify the factors impacting disease-free survivals, we will compare different variables and have interesting results. As you can see in the left graphical presentation, that the patients with positive margin have a disease-free intervals of about 16% as compared to 39% of patients who had clear surgical margins. And on the graph, the patient with larger burden of cervical nodal disease has disease-free interval of 21% versus 38% of patients with no or lower burden of cervical nodal metastasis. So going towards the conclusion, with this we can conclude that although advanced stage disease is associated with high chances of recurrence, but even in this group of patients, those who have clear surgical margins and a smaller burden of cervical disease do better and have more chances for better outcomes. However, further improvement in risk stratification can be achieved with molecular studies of tumor cells to target therapy. This is still under investigation and can transfer the current treatment protocols or procedures in future. All right, thank you. If you have any question and answer, you can ask me.
Thank you, Dr. Saeed. Unfortunately, you have used your 10 minutes. We have actually gone beyond that. So we don't have time for question and answer session. I'm going to move ahead on and we're going to ask next presenter, Dr. Abdullah Salim, to come and present. He is going to be presenting on correlation of central line associated bloodstream infections, internal central venous catheters, and levels of absolute neutrophil count at the time of insertion in pediatric cancer patients. Dr. Abdullah Salim is from Shaukat Khanum, Lahore. Once again, I would like to remind all the presenters, please use 8 minutes for your presentation and leave 2 minutes in the end for question and answer session. This is a online meeting webinar, so we are pretty much restricted on time. Thank you very much. And I am going to ask Dr. Salim to take over and you're going to hear from him now.
Hi, everyone. I'm Dr. Abdullah. Thanks for introducing me. And my research topic today is correlation of central line associated bloodstream infection in tunnel central venous catheter and the levels of absolute neutrophil count at the time of insertion in pediatric cancer patients. Sorry. I have no conflict of interest, and the study was approved from IRB Shaukat Khanum Hospital, which is Institutional Review Board. So what is central venous catheter? Central venous catheter is an indwelling device that is peripherally inserted into some larger veins and advanced until the terminal lumen resides within the one of the major vessels, either inferior vena cava, superior vena cava, or right atrium. So this technique is called central venous access. So there are two types of central lines, non-tunneled and tunneled catheter. The non-tunnel catheters are temporary central venous catheters that are inserted percutaneously, and these accounts for most of the Klebsiella infections. While tunnel catheter are implanted surgically by creating a subcutaneous tract before entering some larger vein, either into the internal jugular vein, subclavian vein, or femoral vein for long-term survival for like weeks to months. So this is one of these tunnel catheter. You can see there is a cuff placed in place to remain the tunnel catheter in place. Uh, Okay, what is CLEPSI? CLEPSI is a laboratory confirmed bloodstream infection where an eligible bloodstream infection organism is identified, and an eligible central line is present on the laboratory confirmed blood infection on the day of event or on the day before. So there are 25,000 bloodstream infection occurs annually, and most are related to the presence of intravascular devices. Um, so why Klebsiella is so bad? It increases the length of hospital stay. As you know, our specialized hospital is cancer hospital, and most of the population comes from all over the country and from the neighboring countries. So so there is limited capacity of beds, and there are higher healthcare costs for introducing the tunnel catheter, and in case if it got infected, so we have to remove it, which is quite costly for us. And there is increased morbidity and mortality for the patient. And because we are having a retrospective study on this pediatric population, sorry. So as also as not only the patients suffer, but also the parents and the guardians also suffer. There is both mental and physical trauma to the patient as well as to the parents, because this is an invasive procedure. So we have to do it in general anesthesia. So there is also implication related to the anesthesia. So we have selected. Can it be minimized? Okay. So our population includes, we have selected the patient from July 2018 to July 2020 in Shaukat Khanum Hospital. Patients were investigated retrospectively and the data was collected. Patients were divided into 3 groups. In group 1, there is mild decrease in ANC level from 0.6 to 1.3. In group 2, there is moderate decrease in ANC from 0.23 to 0.06. And in group 3, there is severe decrease in ANC, which is less than 0.3. Okay, total number of tunnel catheters inserted from July 2018 to 2020 were 125, and out of these 25 lines got infected. And the overall total number of neutropenic patients from in which tunnel catheter were inserted were 35, out of which 6 were infected in neutropenic patients. So total numbers were 125 and 25 numbers got infected. The total number of neutropenic patients were 35, and 6 of them were infected. In group, total number of 18 patients were included, and the number of lines got infected in mild neutropenic, which is group 1, were 3. While in moderate neutropenia, number of lines got infected were 1 out of 18. And group 3, which is severe neutropenia, which is less than 0.3, the total number of severe neutropenic patients were 11, out of which 6 of them were got infected. So the results were 2/2 chi-square was applied, and the p-value turned out to be 0.659. The results were not significant. To check the association between neutropenic versus non-neutropenic patient, Fisher's exact test was applied, which showed the value of 0.8041, which is also showing poor association. So our study shows poor correlation of CLAPSI with low ANC at the time of insertion. Whether these low ANC level patient can proceed for tunnel catheters safely without getting infected, we need to have further prospective studies with multifactorial and multi-departmental involvement. Thank you. Thank you, everyone. Thank you for the Dr. Saad and Dr. Khurram for helping out in this presentation. Thank you.
Thank you very much, Dr. Abdullah Salim. If anyone has any questions, I see Dr. Vakas has unmuted his mic. I think he has a question for you.
Okay.
Dr. Vakas.
What about the international data in terms of neutropenia relation with CLAPSI? So is there any data that the severe neutropenic patient develop more CLAPSI in this population?
There are guidelines for neutropenic patients, but they are not divided into either mild, moderate, or severe. In most of the time, as per guidelines, neutropenic patients are avoided for central venous catheter. So as comparison to the in comparison, like mild, moderate neutropenia, there is no study I have in which I have known.
So many of the neutropenic patient can have, like they normally can have pancytopenia result in low platelets. So in your studies, what's your cutoff, for example, when you put the central line or tunnel line?
Our cutoff for platelets is 20,000. And we often arrange mega units in case something uneventful happens. But most of the time the cutoff value is 20,000.
Thank you very much.
Thank you.
Now I'm going to ask Dr. Sana Afzal Khan. I apologize for the miscommunication. She's going to be presenting on assessment of the procedure of informed consent and impact of stimulated training in anesthesia trainees. Dr. Sana is also from Shaukat Khanum, Lahore.
Assalamu alaikum, everyone. I'm Sana Afzal, and I'm a resident in anesthesiology working here at Shaukat Khanum. I will be speaking about a study that was done on the assessment of procedure of informed consent and the impact of simulated training in anesthesia trainees working at Shaukat Khanum Hospital. So most of us are fairly familiar with the concept of informed consent. It is a process which includes disclosure of information to the patient, making sure that the patient has comprehended this information well, and then taking a written authorization to go ahead with the procedure. In order to make sure that the informed consent is valid, we need to ensure that the patient is competent and is taking a voluntary decision. Before speaking of the ethical legal implications of taking an informed consent, I would like to bring to notice that the doctor-patient relationship has undergone transformation over years. So the previously followed paternalistic model is no more applicable, it's redundant, and patient is becoming more and more of an active participant in medical decision-making. This greater autonomy that we are giving to the patients is what makes the basis for medical ethics. Secondarily, an informed consent also protects doctors or treating physicians from professional liability issues. Thirdly, a written informed consent is necessary for a hospital record because the hospital needs to have proof that informed consent did take place between the two parties. From Bolam to the Montgomery case, there has been an evolutionary change in medical practice from a conventional to a more modern approach towards informed consent. The conventional approach meant that the doctors were expected to reveal information or disclose information that they deemed appropriate for the patient. Whereas the modern approach now makes it mandatory for doctors to reveal all information and material risks that a reasonable patient would want to know before taking or making an informed decision. It is pertinent here, speaking of a detailed informed consent, it is pertinent to mention the hospital policy for an informed consent. All these 7 elements need to be met for an informed consent to be valid. So taking an informed consent is a fundamental skill, and all anesthesia residents are expected to have mastered this skill during their training. This, however, may prove to be challenging, and I will touch upon a few obstacles that might be there which may make this process challenging. Firstly, we have long lists which are sometimes very time consuming, and taking a detailed informed consent from each patient might become difficult. Secondarily, we also have during a consent taking process, there might be a perception bias from the patient, from the doctor who is taking the consent. Thirdly, we have a lot of day case surgery, which means that we are meeting the patient for the first time right before the induction of anesthesia. And at that point, the anesthetist or the trainee might feel reluctant in expressing the risk of serious complications or the risk of death. Fourthly, we also have a social linguistic barrier with some of the patients, which may make it difficult for us to explain all elements of an informed consent in detail. So the objective of this study was to assess the baseline skills of trainees pertaining to informed consent, simulated training and feedback to help the trainees overcome deficiencies, to emphasize and reiterate the importance of all elements of an informed consent in order to make it valid. Thirdly, the assessment of retention of skills. It is important to mention here that the process used in training was a simulated training process, which is in general used for technical skills or medical procedures, whereas this was one of the first times that it was used for a non-technical skill such as informed consent. The study procedure was simple. A written questionnaire was devised, and 16 anesthesia residents were selected for the study. A baseline assessment was done on a simulated patient. 1 week after this, a 1-hour training session was organized, which consisted of simulated training, video assistance was used, one-to-one faculty teaching was done, feedback was taken, and another assessment, which was called the post-simulation assessment, was done. 4 weeks from this, a reassessment was done, and this was done on an actual patient. This was done to assess the retention of skills. Lastly, the data was compiled and analyzed. So this is the checklist that was used. This checklist has been adapted from a study done in University of Stanford in 2016, and the checklist was made by the modified Delphi process. It includes 11 elements, starting with the introduction, indications of procedure, moving on to benefits, using clear and simple language, pausing for questions, describing minor risks, then serious risks and emphasizing that these are rare, description of alternatives to the procedure, teach back, having the patient verbally agree, and then utilizing the process of connect, introduce, communicate, ask permission, respond, and exit. Out of the 16 anesthesia residents that we had, 68% were from first year and second year, and 32% were from third and fourth year. This is a line chart showing the number of elements being met through the course of this study. As you can see, at baseline assessment, 52% of elements were being met, and this continued to increase through the course of the study, and it came out to 90% at the retentional skin assessment, which was the final assessment. Speaking of the baseline assessment, these were few of the most poorly performed elements. Teach back being the most poorly performed at 0%, followed by the risk of serious complications and emphasizing that they are rare at 18.8%, followed by minor risks at 37.5%, and the description of alternatives to a procedure at 43.8%. This is a bar chart showing comparison of baseline, post-simulation, and final assessment stages of all the elements in the checklist. And you can see that through the course of the study, the number of elements being met consistently increased. Teach back was still the most poorly met element at the end of the study, but it had still increased from 0 to 37%. Later, this data was also analyzed using the McNamara test, and we saw that the p-values were significant for most of these elements, except for introduction, which was 100% even in the baseline, and indications and using clear and simple language, for which the p-values did not come out to be significant. Another analysis was drawn. This was a comparative analysis of trainees of the first year, second year, third year, and fourth year. And we had two observations. The first observation was that regardless of the experience of the trainee, the number of elements being met during the course of the study increased for all residents. Second observation drawn was that with increasing number of years of experience, the number of elements being met in an informed consent also increased. This, however, did not hold true for the fourth year. But this could be possible because we had a very small sample size from fourth year. We only had 2 residents. So this was a single-centered study. Sample size was small, and we had residents from first year to fourth year. So that could have skewed the data a bit. These are a few limitations of the study. Conclusively, number of animals met in informed consent improved for all trainees, regardless of their experience. And we believe that the process of simulation which was employed greatly enhanced the results. Thank you.
Thank you very much, Dr. Sana. This was a very well done presentation and study, I must say. So this was interesting, though, that the final year, even though there were 2 residents, they did score less than the other lot. Anything else? Were they assigned more duties, that they had less time to take consent? Could that be a reason? Or do you think it's just generally they think they, I don't know, what else could be a reason other than sample being skewed, though? If you
Of
had
course,
to
it's
think of
possible.
anything.
It is possible they do have a greater share of duties. So that's possible. They have lesser time. For looking into other reasons, more study has to be done. More residents need to be taken from 4th year.
And what about the teaching back element? We see that even though after all the training, they still scored less, almost 34%. Do you think that can be further improved? Are there other techniques that you guys looked into that in future you can employ in order to improve that?
So in this study, we've just used the process of simulated training, which involved, we had a PowerPoint presentation. We did use videos. We also did one-to-one faculty training. So I'm assuming if that's still taken the results to 37%, more emphasis on this particular element of teach back might improve the results more.
Great. I do have one more question that has come up from one of the attendees. It's how was observer bias removed?
So the observer was part of the hospital team, so that bias could obviously not be removed, which is why we would probably want this study not to be single-centered, and we would want to recruit more residents into this.
Were there just one observer who was observing all the residents, or there were multiple observers?
So in first and second assessments, which were done on a simulated patient, we had a simulated patient, had one person, there was a person.
So I'm sorry, your video did break. So I'm assuming the answer was there was 2 different people who were observing, correct?
Yes, they were, yes.
Okay, and what, okay. That's good. I think we are done with the question and answer session. We're out of time, but thank you so much. Next person, who's last but not the least of the lot in this session, is Dr. Mahir Akram, presenting a topic on compliance with American Thyroid Association guidelines in patients with thyroid tumor. Dr. Akram is also from Shaukat Khanum Hospital, Lahore Center. He will be starting. I see that his presentation is up. I'm going to ask him to take over, and now you're going to hear from him.
Good afternoon, everyone. Thank you, Dr. Shariar, for introducing me and the topic. Firstly, I'd like to thank Shaukat Khanum for providing the opportunity to present this clinical audit. I have no disclosures to make. So beginning with what actually is a clinical audit, it is a review of clinical performance, the refining of clinical practice as a result of measurement of performance against agreed standards. And the standards that we used for this audit are those that are outlined by the American Thyroid Association. Although there are a number of organizations and associations, but the guidelines that are outlined by the American Thyroid Association are those that are widely used and the most commonly accepted. The most recently updated guidelines, that is the 2015 version, was used for this clinical audit. There are about 101 recommendations, which cover almost all aspects of the thyroid cancer. However, 45 of these are those which cover the clinical evaluation, the surgery, and the perioperative period. From these 45s, the one that we selected were as follow. The preoperative ultrasound neck is recommended for all patients undergoing thyroidectomy for malignancy or for suspicion of malignancy. Ultrasound guided FNA of sonographically suspicious lymph nodes, that is size of greater than 8 to 10 millimeters, should be performed in all patients. Preoperative use of cross-sectional imaging such as CT or MRI is recommended in addition to ultrasound for patients with suspicion of advanced disease. Routine preoperative PET scan is not recommended. Likewise, routine preoperative measurement of serum thyroglobulin or thyroglobulin antibodies is also not recommended. Prior to the surgery, the surgeon should communicate with the patient regarding the surgical risks, including the nerve and the parathyroid injury. All patients undergoing thyroid surgery should have a preoperative voice assessment. This should include both the patient's description of any vocal changes as well as the physician's assessment of voice. A preoperative laryngeal exam should be performed in all patients with preoperative voice abnormalities, history of upper cervical or upper chest surgery, and those with known thyroid cancer with posterior extrathyroidal extension. During the surgical procedure, visual identification of the recurrent laryngeal nerve should be made. The parathyroid glands along with their blood supply should be preserved and identified during the surgery. Patients should have their voice assessed in the post-operative period. In case of any abnormality, a formal laryngeal exam should be performed. Intra-operative findings as well as the post-operative care plan should be communicated by the surgeon to the patient in the post-op period. Serum calcium monitoring should be done in all patients in the post-operative period. In those with hypocalcemia, and endocrinology review should be sought for the management. So the objective, as being outlined in the title, was to determine the compliance with the American Thyroid Association guideline for the management of patients with thyroid tumors. This is a retrospective cohort audit conducted at Shaukat Khanum Memorial Cancer Hospital, Lahore, after approval from the Quality Assurance Department, covers a period of about 1 year from March 2019 to June 2020 and includes about 100 patients. These patients were all those who underwent thyroid surgery with or without neck dissection, those with previous history of surgery outside the hospital, those with age of less than 18, and those with incomplete or missing data were excluded from the study. The target compliance rate was set to 90% using the research by Goffredo et al. As a reference that was published in the journal Thyroid. So the mean age of these patients was 37.5 years, with the majority being female, that is 69%. The most common histology was papillary carcinoma, followed by benign thyroid nodules and follicular carcinoma. The most common surgical procedure performed was thyroidectomy. Neck dissection was carried out in 33 patients, and redo surgery had to be done in 6 patients. Now coming to the results of the audit, the compliance rate was 90% for preoperative ultrasound for cervical nodes and for thyroid nodule. In patients with suspicious nodes, that is 38 patients, 35 underwent ultrasound guided FNA, which made the compliance rate of 92%. Preoperative CT and MRI in patients with advanced disease was carried out in 98 patients, making the compliance rate of 98%. Fortunately, none of the patients underwent a preoperative PET scan, and the compliance rate was 100%. Routine preoperative measurement of serum thyroglobulin and thyroglobulin antibodies is not recommended, and the compliance rate in this case was 96%. All the patients were counseled preoperatively regarding the risk to the nerve as well as the parathyroid and any surgical risks. The preoperative voice assessment. This was carried out in only 23 patients out of 100, making the compliance rate of 23%. 99% of the patients intraoperative laryngeal nerve was identified, making the compliance rate of 99%. Intraoperative identification of the parathyroid gland was carried out in 97% of the patient, making the compliance rate of 97%. 99% of the patients underwent a post-operative voice assessment. All of the patients were communicated about the intraoperative finding, including the post-op care plan. Similarly, 100% of the patient underwent post-operative calcium monitoring. However, 25 of the patients suffering from hypocalcemia, endocrinology review was sought in only 16 patients, making the compliance rate of 64%. Therefore, we concluded that the compliance with majority of the guidelines was being met. It was above 90%. However, we were lacking in 2 parameters. That was the preoperative assessment of voice, in which the compliance rate was only 23%, and endocrinology consult in case of hypocalcemia, where the compliance rate was 64%. These recommendations, they were presented in the form of a presentation in departmental meeting, and it was emphasized to reinforce the following 2 parameters. That is the documentation of the preoperative voice assessment, as well as endocrinology consult in case of hypocalcemia. We have planned to conduct a re-audit in 3 months to see any improvement in the compliance. Thank you.
Thank you very much, Dr. Akram. I'm going to open the session for question and answers. First, I see Dr. Waqas Shafiq. He has a question for you.
Yes, sir.
Okay, thank you very much. So, Dr. Mahir, did you had a look afterward at how many of these patients actually went home with normal calcium, or the calcium was never rechecked?
No, so all of these patients went home with the normal calcium. What we were lacking is that we were managing these patients on our own. We were not seeking endocrinology review for those with hypocalcemia. The surgical team was managing the patients with hypocalcemia on their own, whereas a proper formal endocrinology consult should have been sought.
Yeah, but they all went home with the normal calcium, so
Yep.
that's one good thing. So what steps you have mentioned that you have started training for the residents? You have done the audit and you are going to do a re-audit in 3 months. What else you think can be done to improve the compliance?
So we need to continuously emphasize and reinforce that we need to carry out both of these parameters, even in the clinics and in the floor. The floor residents, they need to be taught that even if they can manage the hypocalcemia on their own, they should still seek a formal endocrinology review. Likewise, those who are seeing the patients in the clinic, they should be taught that even if they are doing a preoperative voice assessment, the documentation is very necessary. We found out that even though the patients were undergoing a preoperative voice assessment, however, it was not being documented properly.
No, that's good. Thank you.
Okay, I think that is it. Thank you everyone for joining us. This was a very interactive session. I really enjoyed all these papers. I wish everyone good luck. And please do join in for rest of the sessions. This is going to go on for 2 more days. Thank you everyone. Have a wonderful day. Thank you.